going to be talking about an approach of predicting critical outcomes before treatment through functional anatomy analysis. Go ahead. But a Prelude is really, I guess, the broad scope of limitations of D'Amico risk. Most of you, I suspect 90% of you base your treatments on the D'Amico risk category, and that's pretty much it. But you kind of saw yesterday or 2 days ago in some of these large retrospective studies when people have 30,000 patients with D'Amico risk classifications and they try to do data mining to fill in the gaps. You know, we see really impressive studies and great analyses, but you know, for example, in one simple setting of Gleason 9 and 10, Keyshawn and Hamstra kind of looked at the big database and said they either need 3 years or lifetime ADT. There's a paper just published 2 months ago from Yang and some tremendous papers from Yang and the Harvard group. ADT improved overall survival in Gleason 8, but not in Gleason 9 and 10. So look at that spread. One is saying you need lifetime ADT and all the things we talked about not liking, and in the other, and that's for overall survival. So it's a slightly different twist, but it was really, they were saying in this group, Yang's group, were saying we need either different hormones or some other approach for Gleason 9 and 10. So as much as I'm impressed with those gigantic Rube Goldberg analyses, as I called it, they don't solve what we need to solve. But within any D'Amico class, there's a wide spectrum of disease. A lot of these analyses have started to break up high risk and intermediate risk into these subcategories. And I think MRI does reflect the wide spectrum and is really invaluable. So that's just a prelude to the talk. But what I'm going to be talking about is the science of N equals 1, what people call personalized, individualized medicine. And, none of us like N equals 1. We don't like studies of N equals 1, but every day we practice N equals 1 science, meaning we take these massive studies with thousands of patients, try to see what do they have to do with this specific patient. So the reality is you have never seen a patient like this before, and you will never see a patient like this again, right? When it really, really comes down to it, are you experienced? Of course, we're all experienced, but you have to juggle the dials and do whatever you can. So I would say, boy, what a perfect setting to give this talk. Good medicine is like golf, not bowling. Why do people love golf? There's no 2 holes alike in the universe, and you could play the same hole 5 million times and it wouldn't be the same, right? Because your first ball would go one way and your second ball would go in the water over there one day and another day, and you might get pretty good at the hole and managing the hole, but then the wind blows and suddenly the whole thing is different. So what I'm talking about is adapting to the individual challenge is really good medicine. Surgeons know this so clearly about getting in there and saying, wait a minute, this is not how we drew it up on the chalkboard, thinking quickly on their feet, adapting. That's a high pressure, but we don't have that pressure. On the other hand, bowling, every lane is the same. And I would contend there are doctors who are really, really skilled at the golfing, adapting, individualizing treatment. And others really get this regimented black and white thinking of if it's this, then it's this. And that's a big difference for us. How do we get to that? Just combining the two is tough. This is a very tough spare to complete, but I like the golf analogy more. So the players in the drama I'll be talking about are the individual personality, right? We talk about personalized medicine. We actually realize the personality has a massive amount to do with the decision that's made, right? Someone comes in and they already are preloaded with a very strong conviction of what they need. And so to me, that is fascinating in itself. It's something we've never looked at academically. We're over in our evidence-based bunker and we're saying, what's the best treatment we can give you? And yet patients come in and they may want X. And you just think about this. They have a momentous decision before them and they have a gut-level reaction. That might be right, might be wrong. But then there's the individual functional anatomy, which is variant, individual tumor anatomy, which is variant, and then finally the multidisciplinary team. So all of these are going to put together a plan. So if we look in the kind of the biggest philosophical sense at medical decision-making, you have a gold quality of life triangle intersecting with a blue cure triangle. And so at this end, you have cure is of infinite value and quality of life is of no concern. You have a terrible tumor on your arm. The doctor says, I'm going to have to take your arm off for you to live. You don't care about the quality of life. You will do anything in that situation to be cured, right? On the other end, you have cure is of little or no concern and quality of life is of infinite value. So this would be like a low-risk prostate cancer, right? You can, some patients, though, will come in and they will perceive this is a dangerous, terrible thing, and you have to sort of talk them down from the high wire. So in classical, this is rational thinking, right? This is kind of a rational structure of how most people, you would think, make medical decisions. Not so, though. I think anyone who has really done this, you know, you talk about modern thinking and modern changes, in the individuals, they size their own triangles. They come to you with radically different personality takes on the whole problem. So here you got a guy with cure is quality of life. Why do we have to stop the hormones after 2 years? Let's just keep going. I mean, I've heard that. You know, you heard I'm no fan of ADT, but this patient clearly thinks that's the ticket to ride. Over here, I don't mind being aggressive with radiation, but I refuse to take Lupron. So their triangle's a little different. Here's someone with sort of a balanced view. And then this is kind of some person that doesn't even, you know, it is not worth it to me to go all through this. In the end, I put myself in God's hands. I don't have any symptoms at all from this. And that's a person who has a totally unique orb of decision that doesn't even engage this whole thing. So it's interesting. And so we're presenting to these varietals, and they're not even varietals, they're individuals. Every single one is different. So then if we look at the functional anatomy variant, so you have all those personalities, now you have all these functional anatomy differences. This is a long external sphincter. The internal pudendal artery is separable from the prostate by a mile. This person has a nerve bundle right where Patrick Walsh said it should be. This person has a very short external sphincter. The vessels come right up to the prostate, and they have a plexus of nerves over the entire surface of the prostate. And so these challenges are very, very, very different, and I'll talk about how we navigate that. Then you have a multidisciplinary team that's supposed to be sort of the evidence-based, but there's a lot of variation in how this is structured. I would say when I started my career, it was a competitive adversarial medicine barker. You go to the surgeon and he'd say, whatever you do, don't have radiation therapy, they're gonna burn you. And you go to the radiation therapist and they say, whatever you do, don't have surgery, you're gonna end up incontinent and impotent, you'll regret that decision the rest of your life. So that was how destructive that was for patients to have that structure to navigate, right? Really, really ugly structure. Then it got to it's all good, your call, which was for some patients maddening. For some patients, they embraced that. But for some patients, you're not going to tell me what to do? What would you do? You know, this is really basic. So this neutrality is unhelpful. Then you have mutual respect, which I think, you know, Jim Monty was a great urologist. He believed in surgery, but he was incredibly fair. Dr. Stone is incredibly fair to radiation because they've worked in it and with it, and you just have a basic respect. But if you asked Jim Monty what to do, he would still say you need surgery, because that's what he knows, and that's what he knows best. And then finally, I would say advocacy. That this is the supreme level that we could get to. I'm trying to get to that, and how to be helpful, how to be most helpful to this individual patient with their very, very, very unique N=1 situation. So simplest use, sphincter length predicts post-op continence. Nice studies on that. Nerve bundle configuration predicts sexual function, and tumor extent and extension predicts surgical curability. So patients can know ahead of time, your tumor is sticking out the side, you can have surgery if your gut tells you to, but you're gonna need radiation therapy after. Instead of the ultimate, most bitter person in the world, that the surgeon said, let's get it out of there. You know, if you don't get it out of there, you're not gonna be cured. And then they come back to see the surgeon and hear they didn't get it all out of there, and now they're going to need 7 weeks of radiation. If you want to see a bitter patient, then just don't tell them about the possibility of radiation after. So bladder neck variants, these are extreme. I mean, this is helpful information to know ahead of time, though, and this is, I'm just going to contend that MRI gives you tremendous head up on this. So Class 1, perfect bladder neck, perfect configuration, nice little funnel. Class 2, you see the bladder neck starting to space apart, not too impressive. Class 3, you kind of have a barnacle bill prostate here, a gnarly looking thing growing up right into the prostate or into the bladder. And then finally the classic median lobe, the overarching median lobe that has a functional correlate in some patients, but there are some patients that pee just fine with a median lobe. So having this information is useful, but structure does not always predict function. This is another thing I learned from Jim Monty. Small glands may have profound obstruction, median lobe patient may have no obstruction, massively enlarged may have no obstruction. And Jim Monty used to say, women have all these problems, Bill, and they don't have a prostate, which tells it as clearly as you could get it. So the external sphincter data, though, this is an MRI coronal view, and you can see the length of the external sphincter extremely clearly, right? Here's the apex, here's the penile bulb. If that sphincter is over a centimeter, your chance of incontinence is really, really low. If it's less than a centimeter, and certainly less than 0.7 centimeters, then you start getting incontinence rate of 20%. So imagine the value of this to a guy whose one scary thought in the world is having incontinence. I mean, we all know patients like that. Everyone has a different triangle, right? So this is very valuable. They didn't say anything about the fact that the sphincter extends up into the prostate, but that's something we have to figure out. Does this matter? This can be very extensive in some patients. I don't think we know, but we do know the external sphincter length matters. But just to give you the idea, this patient over here, look at the length of the external sphincter. It's 2.5, almost 3 centimeters. This person, it's 0.4 centimeters. If you operate on this patient, that paper says you have a very higher than normal likelihood of incontinence. So apex, though, is the greatest cure and quality of life challenge. The apex is pure peripheral zone. It's at risk for tumor. The external sphincter is a functional structure extending into the apex. Nerve bundles terminate in microscopic cauda equina. If you wanted to say the ultimate cure, quality of life, ground zero, it's the apex. Because you need to dose escalate, it's at tumor risk, and at the same time, you have a sphincter immediately adjacent, or possibly, in the worst scenario, growing right up into your target. So you're in a quandary, right? How do you dose escalate a functioning structure? Now we get to nerve variation and say, what do we know about this? Well, there's a lot of interesting changes in this literature. There's 55% have, you can see on MRI, have a bundle configuration. I think you'd all agree. Probably if we put these up and you said, is there a bundle or not, and where is it, you'd all agree on these cases. But 40% have a plexus configuration, and that's just literally these dots around the edge, right? They don't have a bundle. And 5%, really, you cannot see anything. We know the nerves are there, but we can't tell. So the nerve configuration is not settled. A paper in publication states multiple observers agreed on neurovascular identification. I reviewed this paper and I said, this should not be published. Because in the paper, a radiologist pre-screened the patients and excluded 40% due to tumor obscuration. What the radiologist did is took all those cases out that didn't have a nerve bundle. I mean, I hate to say it, but I was pretty livid when this went through, right? So I said, this is ridiculous. I've been trying to get people to agree on nerve bundles for 20 years, and then suddenly someone rigs their trial to do it. But this is not the solution we are looking for. The variation nullifies all prior correlations of dose, so we have all kinds of studies in radiation oncology about dose to nerves, and we'd have to amend them all because half the people didn't have the nerve bundle we thought they had. So this is what I think you can know, though, and this is what I think people could agree on. Elements with sheath, elements without sheath. And by I just mean those little dots, the neurovascular sheath without elements. Then this one has plexus and a bundle, and this one has just a plexus, and then this has none. We can agree on this, but if you have the patient before you, you can know if they have a clear neurovascular bundle and you do a standard nerve-sparing operation, then their sexual function comes in extremely high, 70%. Way higher. But if you do a nerve-sparing operation on someone with a plexus, they will come back with an ED rate of 15. They'll have preservation in 15%. It's an absurd swing. So I don't know why surgeons are so resistant to getting MRIs and having this information ahead of time. Because there is an operation, if you have the plexus, the docs at Henry Ford have done it, called the Veil of Aphrodite, where they literally onion peel the fascia off along the entire prostate and leave these nerves, and they can still get a preservation rate. But you'd have to know ahead of time that that was there. So what I think has happened in the modern era is a big swing. Most of us worry about toxicity. If you see most of these talks, what was the grade 1, 2, 3 toxicity? We are in a very different place. If you look at it with this MR-based planning of everything, we're really in the preservation era, right? We're not talking about avoiding toxicity, we're talking about how much function we can preserve. Walsh started it, but we are in a very interesting place because, you know, with proper planning, we know that you can preserve function. You want someone to walk away from their experience a year later with nothing. No toxicity, no meds, no lifelong malady, and that's the ideal. That's where we all need to go. We are not there yet, but you know, our vessel-sparing radiation publication we did in Lancet in 2016, we had 90% able to be sexually active by patient-reported outcomes at 5 years, and that includes full combination. Most of these patients were unfavorable risk treated with combination. So if you avoid these structures, you can still treatment intensify and get great results. Let's go to cases, though, and how I use this information. Case 1 is a 56-year-old marathon runner with favorable intermediate risk, really smart guy, science teacher. He came in really loaded. He already knew what he wanted to do. His PSA was low. His Gleason was 3+4 in 2 cores. Then it was reviewed as 3+3 in 2 cores later, but when I saw him, he was 3+4 in 2 cores, T1C. And I'm going to just... I guess I can run it. I'm going to give you the preset, his personality preset. I'm sure a doctor knows how to pure and quality of life. Have your cake and eat it too. Why would anyone do anything else? Captain, my captain, why do anything else? So I have a website, I'll take ownership of it, but it's called inmyprostate.com, where I profile all the personalities we run into, because this whole personality thing and how people intrude on our evidence base with their personality is fascinating. So in this patient, though, he went to MRI and he has this anterior T3. So he's a favorable risk. Most of you would have just said he's favorable risk, great prognosis, either do surgery or go ahead and look. This is ugly. This is like the gift of MRI that people keep talking about. Anterior T3, no one anticipated. It's really clear, and to me it's clear that it's outside the prostate. And he's a young man. Surgeon had already said, you're young, you need surgery. But this is a tough spot. And in this coronal view, you see the tumor is really abutting and actually hanging over the external sphincter. So this information was very valuable to the patient. And even the surgeon said, well, we always get beat at the apex anyway. Why don't we just do what I would do, which is just... So you can see how the external sphincter comes up and it's adjacent to this. Basically, most surgeons want good outcomes, right? As much as you think they want to do surgery or, barter, do the medical Barker thing, most surgeons do not want complicated patients. They want a good outcome. And so this... Because he was outside the prostate, I gave him ADT, full response. He had 6 months, LDR plus beam. He's had an excellent quality of life outcome. And so I think this is a case where I would say hard to imagine appropriate treatment with this without MRI. His actual category was not favorable intermediate risk. The average outcome in a 30,000 series of favorable intermediate risk would not apply to this guy. So you need an MRI. I mean, in case I forget to tell you, to properly manage cases in this era, you cannot plan and treat by D'Amico risk. You need the MRI because I'm going to prove it to you in about 4 cases here. So case 2, 54-year-old with high-risk cancer, PSA 7.4, Gleason 8, and lots, pretty good bad disease. T2B versus T3A. His song was, he came in preloaded for surgery. Uh-oh. I think it has to load. I'm sorry, it might take a second here. 'Cause if you understand the word cancer, what it can do, what it's about, you know the only answer is cut it out, just cut it out, cut it out. So, interesting, because this guy has bad disease that's not going to be cured by surgery, but I am very, very mindful of the fact that if you take a patient with this kind of disease to surgery, as long as you give them immediate post-op radiation, they can actually, the cure rates are competitive and they do well. But he has really, again, no question it's outside the gland, right? On the DCE, the white is the tumor. You can kind of see this nice apex lesion. It's sometimes shocking, though. You know, I had him at a questionable T3A, and the MR is real, and it can work the opposite. You know, you don't feel that much, and DRE finds things. So clearly, nice little functional correlate here, right? His nerve vascular bundle lights up over here on this side. On this side, it's completely engulfed. So this is a major surgical challenge, but you have it before they go to OR, okay? And interestingly, his sphincter was extremely long. Okay, 2 centimeters, he has no risk of incontinence. So I was able to tell him, I think with a straight face, that yes, you can have surgery if your gut tells you. I never, ever try to talk people out of their gut because, you know, that's just, I think usually people are right. And, but here's the sad end of this. Here's his sphincter, very long on coronal view, right? Coming from the apex down to the penile bulb, 2 centimeters. This is his post-op scan. He went to a really premier center, world-famous center in Detroit, and he had their latest wrinkle, which was Mohs surgery. So they get in there, they find really high-grade disease. They said, we got a positive margin, you have to take more. Positive margin, you have to take more. And they basically ended up excavating the entire external sphincter. It's just gone. He comes back to me, said, Dr. McLaughlin, you said I wouldn't have any trouble with continence, but look what happened. And then I took this, and it is shocking. It is shocking that happened because he's got full open, wide open diaper incontinence that he's managing, and he's gonna need an artificial sphincter, which is not the end of the world. But again, just think of the functional correlation here. It's a very sad outcome. And so, again, yeah, nice big long sphincter, now all the way down to here. Interestingly, this guy had Gleason 5 component, extra margins everywhere. His PSA did not go down to 0. We had this talk, in Jason's talk. He was told, wait, you don't need radiation. Wait till the profile from the genetic testing comes back. I said, do not pass go. Get in here, we'll simulate and get started. It was one of the most absurd things. So we were done treating him, and he said, guess what, Dr. McLaughlin? They gave my genetic profile, and they do think it's a good idea for me to have radiation. So we got to get on the same page. This whole crazy thing, Jason said it. What are you afraid of in sending patients for immediate post-op radiation? What is going on with that? Because I use MR. In this guy, I would have used MR and avoided that sphincter post-op, right? My urologists do not complain about the radiation outcomes when I use MR and don't cream the whole thing down to the penile bulb. It's a world of difference. So, conclusion, personality play a major role in complex treatment decisions. We have to figure this out as academicians, because patients can come in and we put all the evidence before them and their personality decides. We have not begun to sort this out. Surgery is, on a psychological level, the obvious choice for some, right? You want primal gratification. But again, the website goes through this. Then I have a 46-year-old actuary. Wow, knows more stats than any of us, right? Brilliant guy. His initial diagnosis was favorable intermediate risk, really low. He was 2 cores, 3+3, then changed to 3+4. So he needs treatment. His MRI, though, was obscured by hemorrhage. We did it a little too early, but he had perfect classical anatomy for surgery. So his preload, though, being a very, very philosophical, mathematical-minded person, treat or not to treat it, sometimes less is more. Sometimes less is more. Sometimes less is more. That was his theme song. Even at 3+4, he was completely okay with watchful waiting, because the studies that are out there say for 10 years, with a 3+4, you have a low incidence of that. So what did I recommend? Anyway, what I recommended was surgery. Whoops, sorry. Shut up. He was very persistent. But he came to me. It's an interesting story. He first saw one group, and they said, do SBRT. It's the latest, greatest thing. Then his friend from high school said, go see Bill. That's me. Get vessel sparing, best cure and quality of life long term. And he comes to Bill, and what did I tell him? I told him, you need surgery. You're 46 years old. I live in a small town. I do not underestimate in a 10, 20, 30, 40-year time span the risk of secondary tumor from radiation. I've had patients I've treated successfully. 15 years later, they get a horrible bladder cancer from hell, and they're dead by 20 years. Well, what if that was the scenario with him? He's 46 years old. So again, in this advocacy role, and I mean, I have had patients and their wives almost fall out of their chair. Wait a minute, let me get this straight. You're a radiation oncologist and you're telling us you should have surgery, in my opinion. But the advocacy role is very clear. You know, I'm not there to talk them into anything. I'm there to do what's best for them, and I think many would disagree with me on this. They'd say, give them SBRT, deal with the small secondary risk down the road. It's a small risk. Why are you decisive? I'm only pushing that because he's 46 years old. He's got decades ahead of him. So he ended up going to surgery and actually had a great outcome. He had perfect anatomy, went to a good surgeon, really excellent cure and quality of life outcome. Case 4, 54 years old, T3 by all measures, almost T4. I mean, this is a horrible disease. On biopsy, he was 4+5. This is sort of the classic lethal prostate cancer, right? It's this whole animal unto itself. And by all measures, I'm including MR, but his preload was testosterone. He had the most wonderful relationship of his life. He had finally found the woman. They had this incredibly intense, wonderful relationship going. To the eye, it was sort of one of those daughters with benefits. I mean, there was quite an age disparity, but they were very happy. These start so well, right? These start so well, they don't end well. But here's his song. And he literally said, "Doc, doc, doc, please don't."
Just kiss and moan, cause you took away my testosterone. Best drug I've ever known. I've tried a few, I'm here to say testosterone can make my day nice. It'll make my day nice.
So, I mean, now, the reason he reacted that way is because I did inform him, you need this. So I think people had the idea I'm against ADT. I am not against ADT. I am against 2 years of ADT if there's another way out, okay? And I think there are ways out for some patients. But actually, this was another kind of happy ending. I kind of gave him my mother's old line, if it's true love, it'll go through any trial or tribulation, you know? So... It actually did. It worked out. So, but advocacy neutral position. There is a role for surgery in young. Oh, this is. I'm sorry. This is the slide I was trying to fix out of date. So tally MRI pre-treatment may predict post-treatment outcomes, quality of life outcomes that are absolutely critical to patients. A friend called me. He was going to surgery. He had an MRI and he had a 0.3 centimeter external sphincter. I said, you can have surgery if that's what your gut tells you, but you have a very real risk of incontinence. And so this is gold. and it's for free. You just get an MRI. And advocacy position helps, though. This is where we should be in 2019. We shouldn't be medicine barkers trashing each other's work. I have deep respect for surgery. I think there's some patients, as you can see, where I would send them to surgery. I would not talk them into radiation. I don't always have that favor returned from the urologist, but respect the individual, honor their deepest wishes, but give them some information to actually make a good decision, right? I mean, they're just going on their gut. So that's it, and thank you.